I'm delighted to have you as part of this community. Welcome, welcome, welcome. Welcome to our video on health in Norway. We're thrilled to have you here. Health in Norway, with its early history of poverty and infectious diseases along with famines and epidemics, was poor for most of the population, at least into the years. The country eventually changed from a peasant society to an industrial one and established a public health system in 1860. Due to the high life expectancy at birth, the low under 5 mortality rate and the fertility rate in Norway, it is fair to say that the overall health status in the country is generally good. In this section, we'll be deep diving into population data, unraveling its complexities and uncovering valuable insights. Norway has a birth, death, cancer, and population register, which enables the authorities to have an overview of the health situation in Norway. The total population in Norway as of 2018 was 5,295,619. The life expectancy at birth was 81 years for males and 84 years for females 2016. The under 5 mortality per 1,000 live births in 2016 were 3 cases, and the probability of dying between 15 and 60 years for males was 66 and 42 for females per 1,000 in population. The total expenditure on health per capita was $6,347 in 2014. Total expenditure on health as percentage of GDP was 97%. Gross national income per capita was $81,807 2018. Without further ado, let's move on to the topic of fertility. The total fertility rate per woman in 2018 was 162, while the regional average was 16 and global average was 244. Prevalence of tuberculosis was 10 per 100 in population, and the regional average was 56 while global average was 169. In Norway today, there are 5,371 HIV-positive people, 3,618 men and 1,753 women. In 2008, the incidence of HIV-positive people had a peak and the highest incidence of HIV-positive. Since that, there have been a decrease in new cases. Get ready to uncover the mysteries surrounding Human Development Index as we navigate its intriguing terrain. Norway was awarded first place according to the United Nations Human Development Index (HDI) for 2018. A new measure of expected human capital calculated for 195 countries from 1990 to 2016 and defined for each birth cohort as the expected years lived from age 20 to 64 years and adjusted for educational attainment, learning or education quality, and functional health status was published by The Lancet in September 2018. Norway had the 7th highest level of expected human capital with 25 health, education, and learning adjusted expected years lived between age 20 and 64 years. Demographic measures for Norway. Total population 2018 5,295,619. Gross national income per capita PPP International 2018 81,807. Life expectancy at birth years 2017. Probability of dying before the age of 5 per 10 live births 2017. 3 probability of dying between 15 and 6 years per 10 population 2016. Total expenditure on health per capita in 2014 $6,347. Total expenditure on health as percent of GDP 2014 9.7. In this part of the video, we'll be diving deep into history and unraveling its profound impact. In the early Norway faced major challenges. The differences between rich and poor were large, living conditions poor and infant mortality high. Economic conditions in the country improved, but some social groups still lived under constrained conditions. The nutritional status was poor as well as hygiene and living conditions. The conditions and class differences were worse in the cities than in the countryside. Immunization against smallpox was introduced in the first decade of the 19th century. In 1855, Gaustad Hospital opened as the first mental asylum in the country and was the start of an expansion in treating people with such disorders. After 1900, living standards and health conditions improved and the nutritional status improved as poverty decreased. Improvement in public health occurred during development in several areas such as social and living conditions, changes in disease and medical outbreaks, establishment of the healthcare system and emphasis on public health matters. Vaccination and increased treatment opportunities with antibiotics resulted in great improvements. Average income increased as did improvements in hygiene. Nutrition became better and more effective, also improving general health. In the ERS, the situation improved in Norway and, as a result of decreased poverty, nutritional status improved. Within 100 years, Norway became a wealthy nation. Even though Norway experienced a setback during World War II, the country achieved steady development. Improved hygiene led to fewer infectious diseases and scientific discoveries led to breakthroughs in many fields, including health. However, an economic downturn in the ERS exacerbated the nutritional situation within the country. Nutrition therefore became an important part of social policies. In periods there were high rates of unemployment, and poverty affected women and children most. Children often had to walk long distances to get work as shepherds during the summer in order to help their families with income. In mining towns as Rose, children also had to work in the mines. Living conditions improved during the ERS. From being a poor country, Norway developed within 100 years to become a wealthy nation. Even though the country experienced a setback under the Second World War, the country achieved steady development. From 1975, Norway was self-sufficient in petroleum products and oil became an important part of the Norwegian economy. Improved hygiene led to fewer infectious diseases and scientific discoveries led to breakthroughs in many fields, including health. After 1945, smoking became a relevant factor. While infectious diseases decreased, chronic diseases such as cardiovascular disease were blooming. From 2000, life expectancy was still on the increase. There are, however, still social differences when it comes to health. While globalization increases the demand for infectious control and knowledge, the Norwegian population demands more from the government in regard to health and treatment. In this section, we'll be exploring infant mortality. Early on, there were no statistics kept for the whole country on infant mortality, but in Asker and Brum in 1809 infant mortality was 40% for all live births. In 1900, infant mortality was higher in Norway than in any other European country. Development of the welfare state has contributed to a great decrease in infant mortality rates. This can be attributed to better nutrition and living conditions, better education and economy, better treatment possibilities and preventive health care, especially immunization. The infant mortality rate increased again between the 1970 and 1980 due to sudden infant death syndrome (SIDS). SIDS was unknown from earlier, but the increase was dramatic. The trend was reversed when Norwegian parents were encouraged to lay their children on their backs and not their stomachs when sleeping. The time has come to unravel the secrets behind population and gain a deeper understanding. At the beginning of the 19th century, the total population was just under 1 million. However, it doubled within the next 100 years, even though many decided to emigrate. Industrialization resulted in many people emigrating from the countryside to the major cities for work. At the beginning of the ERS, the population was 2.2 million and increased to about 4.5 million through the ERS. 15% of the country's population lived in Oslo and Akershus. The proportion of people associated with agriculture, forestry and fishing declined while the percentage affiliated with industries increased. As we transition to the next segment, let's unravel the mysteries surrounding communicable diseases and gain a fresh perspective. The Norwegian government recognized that the population needed to improve its health if the country was to become a nation with strong economic development. Cholera and typhoid fever were common communicable diseases in the ERS. Norway experienced several epidemics. Cholera was the worst. The last epidemic outbreaks were around the Ers. Even though these were not as severe as the Black Death in the Ers, mortality rates were high. Sexually transmitted diseases also caused widespread problems. These were, however, not defined and divided into gonorrhea and syphilis until later. Smallpox was the most serious disease in the years around 1800. Legislation for vaccination against smallpox was introduced in 1810. At first, the law was not strictly enforced, but when people were commanded to show their vaccination cards at confirmations and weddings, there was an increase in the vaccinating of children, and Norway finally gained some control over this disease. Leprosy, also known as Hansen's disease, ravaged the west coast of Norway. Patients were isolated in leprosy hospitals with room for up to 1,000 patients. Gerhard Armer Hansen, 1841–1912, working in Bergen, discovered the leprosy bacillus. He revealed the association between hospitalization for infected patients and a decrease in the number of new cases. Tuberculosis caused many deaths in the late Ers while leprosy rates declined. Mortality of tuberculosis was high around 1900, but decreased steadily for the next 50 years. The greatest decrease in tuberculosis happened before vaccinations and medical treatments were available. The decrease was caused by improved living conditions, nutrition, and hygiene. The Spanish flu of 1918 affected the country. This influenza pandemic took many lives, especially those of young people who lacked immunity to the new flu virus. Diphtheria, a common childhood disease, raged during the early years of World War II. But with new vaccines available, the country experienced an immediate positive response. Polio had its last major outbreak in 1951 when 2,100 cases were registered. In 1956, immunization of polio started. Let's now shift our focus to discovery of microbes and explore the ways in which it shapes our perspective. In the late Ers, microbes were discovered and prevention of diseases were now possible. Until now, spreading of infections had only been debated. With new discoveries within the field and greater understanding on how bacteria and viruses transfer and spread among humans, it was possible to make significant changes in treatment and care of patients. One example was to isolate people with leprosy and tuberculosis in order to stop spreading. Let's now turn our attention to antibiotics and uncover the fascinating insights it brings to the table. In the Ers, many vaccines were developed, and the first antibiotic, penicillin, came about in the Ers. These introductions were very powerful tools in preventing and treatment of childhood diseases. In this part of the video, we'll be diving deep into vaccines and unraveling its profound impact. More vaccines became available and the child vaccination program was growing rapidly. Almost all feared childhood diseases were going extinct. Vaccines against measles, rubella were introduced to the childhood immunization program in 1978. Rubella is dangerous to the fetus if the mother is affected during pregnancy. Today, all children are offered free vaccines and the offer is voluntary. The coverage for most vaccines is high. Without wasting any more time, let's jump into the fascinating world of HIV/AIDS. In the early Ers, AIDS came as an unknown disease. Norway was early in preventing it in high-risk groups through information campaigns. The HIV virus was later discovered and HIV tests became available from 1985. As we transition, let's shed light on cardiovascular diseases and its relevance to our ongoing exploration. Incidences of tuberculosis became fewer and an increase in cases and mortality of chronic diseases appeared, especially cardiovascular disease. Tobacco is one of the most important causes of cardiovascular and cancer diseases. During World War II, the tobacco use in Norway was limited because of strict rationing. After the war, sale of tobacco bloomed and so did the implications from consuming it. In the late Ers, chronic diseases were dominating, and because of increased life expectancy, people lived longer with these chronic diseases. Around millennium, new treatment and prevention for cardiovascular diseases ensured a decrease in mortality. However, these diseases are still one of the greatest public challenges in the country. The incidence of coronary heart disease in Norway reduced significantly between 1995 and 2010, with about 66% of the reduction due to changes in modifiable risk factors like activity levels, blood pressure, and cholesterol. Mortality reduced from 137 per 100,000 person years to 65. As we venture forward, let's examine lifestyle diseases in detail and gain a deeper appreciation for its significance. Lifestyle diseases are a new concept from the second half of the years. Tobacco use and increases in cholesterol levels show a strong correlation to higher risk of cardiovascular disease. Let's now turn our gaze towards mental health and explore the fascinating connections it has to offer. Mental health services are part of the Norwegian special healthcare services. In some cases, this includes involuntary mental health treatment. The 4 regional health service institutions, owned by the state, receive fixed economic support from the state budget. They are responsible for special health services including mental health care in hospitals, institutions, district mental health centers, child and adolescent mental health services, and nursing homes. In addition to providing treatment, the mental health care services provide research, education for health personnel, and follow-up of patients and their relatives. There are different sectors within the mental health services. District mental health centers are responsible for general mental health service. They have outpatient facilities, inpatient facilities, and emergency teams. Patients can be referred to the district mental health center by a general practitioner for diagnosing, treatment, or admission. There are specialized centers, ideally at central hospitals, for children and adolescents, the elderly, and severe cases such as drug addiction, personality disorders, obsessive-compulsive disorders, and so on. Normally, people who are discharged from treatment at central hospitals are referred to the district mental health centers for follow-up and treatment. Treatment can consist of psychotherapy with or without medications. Physical treatments, such as electroconvulsive therapy, are used for specific disorders. Treatment usually starts at the hospital, with the aim of continuing treatment at home or at the district mental health center. Let's now zoom in on children and adolescents and uncover the hidden gems that lie within. Child and adolescent mental health outpatient facilities offer mental health care for children and adolescents between years of age. Central Child and Adolescent Mental Health Service is aimed at challenges which cannot be handled in the regional state facilities, such as the general practitioner, school nurse, school outreach services for youth and child services. The Child and Adolescent Mental Health Services work closely with psychologists, child psychiatrists, family therapists, neurologists, social workers, and so on. Their aim is to diagnose and treat psychiatric disorders, behavioral disorders, and learning disorders in close collaboration with caregivers. For patients below the age of 16, parents must consent to admission. Without further ado, let's move on to the topic of involuntary care. Involuntary mental health care in Norway is divided into inpatient and outpatient facilities and observation. In involuntary inpatient facilities, patients can be held against their will and can be picked up by the police if needed. In involuntary outpatient services, the patient lives at home or is voluntarily in an institution, but regularly has to report to the district mental health center. These patients cannot be held against their will, but can be picked up by the police in the case of missed appointments. For involuntary observation in hospital, a person can be held for up to 10 days, or in some cases for 20 days, in order for the hospital to decide whether the criteria for involuntary mental health care are met. The Control Committee has as their main task to ensure that every patient's rights are secured and protected in a meeting with involuntary care. Get ready for a thought-provoking discussion as we delve into financing and its impact on our understanding. Mental health services are financed through needs-based basic funding to the regional health services, outpatient clinic refunding, deductibles and earmarked grants from the state budget. Rates for outpatient work are partly based on hours worked and partly based on procedures. There are rates for diagnosing, treatment, and follow-up per telephone or in collaborative meetings. In addition, patients pay a deductible for outpatient consultations. In this segment, we'll be unraveling the complexities of burden of disease and exploring its multifaceted nature. A survey done in 2011 showed that 10.2% of the population of Norway reported to have experienced symptoms of anxiety and depression within the last 2 weeks. The lifetime prevalence of severe depression is estimated to be 15.6%. Treatment and social services for the mentally ill cost society about 70 million Norwegian kroner, more than $10 million yearly. As we move forward, let's uncover the untold stories and fascinating intricacies of life expectancy and death. The report, 2016, shows that life expectancy has increased by 5 years, from 76.8 years in 1990 to 81.4 years in 2013. The reduction in deaths from cardiovascular disease is the main reason for this increase. Life expectancy in Norway in 2017 was 84.3 years in women and 80.9 years in men. From 2007 to 2017, life expectancy increased by 2.7 years for men, but only by 1.6 years for women. This can be explained, for example, by different smoking careers for men and women. As an impact of COVID-19, the life expectancy for women fell from 849 years in 2020 to 847 years in 2021. The following year, the life expectancy for men fell from 816 years in 2021 to 809 years in 2022. In the same year, the life expectancy for women fell to 844 years. Public Health Report shows that the two main causes of death are cardiovascular disease and cancer. The mortality rate of cardiovascular disease has fallen significantly over the past 50 years, and deaths have been largely pushed to age groups over 80 years. In younger age groups, the number of deaths is low. Annually, between 550 and 600 die of suicide, about half past 50 years of age. Compared to other countries, there are relatively many who die of drug-fatal deaths, an average of 260 per year. Deaths due to traffic accidents have fallen considerably. The average number of deaths last 5 years is 138, serious injuries 678. In this section, we'll be shedding light on unhealthy diet and its impact on our understanding of the subject. One of the major findings from the report 2016 is that an unhealthy diet is the most important risk factor for premature deaths in Norway. 46% of all deaths before the age of 70 in Norway can be explained by behavioral factors such as unhealthy diet, obesity, low physical activity, and the use of alcohol, tobacco, and drugs, says Professor Stein Emil Volzit, director of the newly established Center for Burden of Disease at the Norwegian Institute of Public Health. If we consider the population as a whole, it appears that an unhealthy diet represents a greater risk to public health than smoking. This is not because an unhealthy diet is more dangerous than smoking, but because fewer Norwegians now smoke. Since 1990, the percentage of smokers in Norway has decreased from 35% to 13%, explains Volzit. By addressing these risk factors, much of Norway's disease burden could be reduced. Up to 100,000 years of life could be saved if Norwegians ate healthier diets. Approximately 1 in 4 middle-aged men and 1 in 5 women have obesity with a body mass index of 30 or higher in Norway. Among children, the proportion with overweight and obesity appears to have stabilized. Brace yourselves for the next chapter, where we'll be dissecting drug overdose and suicide. Drug overdose and suicide rates are high. Among the under 49 age group, suicide and drug overdoses are the main causes of death in Norway, with the highest rates among the Nordic countries Denmark, Iceland, Norway, Finland, and Sweden. The report shows that lower back pain, neck pain, Anxiety and depression are among the main causes of poor health among the Norwegian population as a whole, while heart disease and cancer claim most lives. Moving ahead, let's uncover the hidden gems within diseases of affluence and discover their significance. A wealthy economy makes it possible to buy tobacco, fast food, sweets and sugary drinks that few people had access to or could afford until after 1950. These days many people have desk jobs, cars, and less demanding housework. In large, physical activity is decreasing. Electronics, computers, social media, and the internet demands more of daily life. Drugs have also become more available in society. New living conditions such as these give rise to new challenges for public health. Only 30% of adults in Norway are fulfilling the advice to stay physically active for 150 minutes per week. As we venture forward, let's examine tobacco in detail and gain a deeper appreciation for its significance. The number of people smoking in Norway has fallen equally for both men and women since 2000. 11% of the adult population in Norway smoke on a daily basis, while 8% are occasional smokers. Daily smoking is most common for the population with low educational attainment. Over the last 2 decades, efforts to reduce the population's exposure to tobacco smoke combined with increased awareness of the health risks of smoking appear to be having an impact. For example, early death from tobacco smoke fell 28% between 1990 and 2013. In Norway 2017, 11% was daily smokers. In 2007, it was 22% daily smokers. The use of snus has during the same period become more common among the population. 12% of the population daily use snus and 4% are occasional snus users. Get ready for an exciting exploration as we unravel the mysteries of non-communicable diseases. The main causes of reduced health and disability in Norway are cardiovascular diseases, cancer, mental health, and musculoskeletal disorders. Annually, 70,000 people are treated for cardiovascular diseases. Technological progress and development within medical treatment have since the years had huge impact on survival of diseases, especially cardiovascular disease. Anxiety and depression are the most prevalent of mental disease. 6% of the population under 75 years takes antidepressants. Other communicable diseases such as COPD, diabetes, and dementia also weighs heavily on the burden of disease. As the life expectancy is increasing, more people are living longer with chronic diseases. As of that, the prescription of drug consumption is high. With our curiosity piqued, let's embark on a dedicated exploration of social differences in health and its fascinating intricacies. The living standard of the Norwegian population has increased, though there are still differences between educational groups. Those with higher education and economy have generally the best health status and live years longer than those with lower educational attainment. New public health legislation Folkehelseloven came into play in 2012, and the purpose of this act is to contribute to a society that promotes public health and evens out social inequalities in health. Get ready for a thought-provoking discussion as we delve into disease in Norway 1990-2019 and its impact on our understanding. Disability-adjusted life years disease is a measure of the burden of disease and an indicator of health status. It is described as the sum of years lost due to premature death and years lived with disability. The burden of disease is divided into 3 categories: non-communicable diseases, injuries, including violence and self-harm, communicable, neonatal, maternal and nutritional diseases. In Norway, the disease per percent has been dominated by non-communicable diseases, NIDs, as displayed in Fig 1 blue. Ischemic heart disease IHD has the highest share with 6.35% of total disease. IHD has remained as the leading cause of disease in both 1990 and 2019, although its prevalence has been decreasing. Back pain has the second largest share of 4.7% of total disease, followed by COPD and stroke that both have 3.92% of total disease. As shown in the table below, the disease lost by strokes have decreased in 2019. Injuries, including violence and self-harm, has led to the second most share of total delays. Falls have the largest share within this area with 3.99% of total delays and has been slightly increasing. This is followed by self-harm with 1.77% and road injuries with 0.9% of total delays, both decreasing. Communicable, neonatal, maternal and nutritional diseases have the smallest share of the total delays. The primary cause within this area is lower respiratory infections with 1.47% of total delays. Lower respiratory infections was one of the top 10 causes of delays in 1990. However, it no longer remains in the top 10 as its prevalence has decreased throughout the years. The neonatal disorders with 0.85% of total delays have also been decreasing, while deerhole diseases are increasing with 0.58% of total delays. Within this group, it is protein energy malnutrition that has the highest annual increase of 2.41% with total delays of 0.33%. 1990-2019 1 ischemic heart disease 1 ischemic heart disease 2 stroke 2 low back pain 3 low back pain 3 falls for COPD 5 lung cancer 5 stroke 6 low respiratory infections 6 lung cancer 7 self-harm 7 diabetes 8 colorectal cancer 8 headache disorders 9 headache disorders 9 colorectal cancer 10 anxiety disorders 10 anxiety disorders. Top 10 causes of delays in Norway, both sexes, all ages. If you have any suggestions for future videos, feel free to drop them in the comments section.